Hello, everyone. Good afternoon. Thanks for joining this American Thoracic Society webinar. My name is Dr. Priya Shetty. I will be facilitating the session today, which is entitled Implementation Science, Rationale, and Global Health Cases. We have a variety of interesting talks lined up for you and time established for question and answer and discussion amongst our colleagues who are here today. A little bit about me, and then I'll introduce my colleagues. I'm an associate professor of medicine and epidemiology at the University of California, San Francisco, where I lead the implementation science training program, and I direct the clinical and population health science course for the Center for Tuberculosis. I'm also a global health tuberculosis researcher and enjoy participating in as many implementation science projects as I can. Our session will have a couple of key points that we hope to illustrate for you today. We aim to provide valuable insight into implementation science and how it might be useful in lung health and in particular in global lung health related activities. We'll begin with an exploration of the rationale for using implementation science as a discipline that might be valuable and provide an overview of its key principles. After that, we'll follow up with a case study from Uganda, in which we'll highlight the application of some of those methods to real-world challenges in programmatic management of tuberculosis. After that, we'll talk a little bit more about the way to integrate implementation science into routine care and routine public health activities, using examples from colleagues in Zimbabwe. By the end of the session, we hope to achieve a few objectives. One is to describe the pressing need for implementation science in the context of global health. The second is to understand the fundamental principles of implementation science and how they might relate to improvement in global health service delivery and public health outcomes. The third objective is to identify promising opportunities where implementation science can be leveraged to enhance healthcare delivery, particularly in low and middle income settings. And finally, to talk a little bit about insights into the facilitators of successful implementation science collaborations between academics, public health program and practitioners, ministries of health, policymakers, and individuals and communities affected by challenges in lung health. Before we continue any further, I'll introduce briefly each of the panelists. We'll start with Dr. Aditya Katamanchi, who is a professor of medicine and public health, as well as chief of the Division of Pulmonary Diseases and Critical Care at the University of California, Irvine. He'll be followed by Dr. Achilles Katamba, who is a senior lecturer at Makerere University in Kampala, Uganda, specializing in epidemiology and implementation science related to tuberculosis prevention and care. And finally, we'll end with Dr. Karen Webb, who is the Deputy Executive Director of the Organization for Public Health Interventions and Development in Zimbabwe, based in Harare, who's bringing over 2 decades of experience in HIV, TB, maternal child health, and program integration. With that, I'll start. Just a few other housekeeping rules. Please put any questions you have during the presentations in the Q&A. I'll be moderating those as we go along, and we'll highlight some of that. We'll open up the discussion to questions after each talk for just 1 or 2 clarifying questions, and then we'll move into a facilitated discussion. Some questions will be answered in the chat directly, but please put them in the Q&A. Okay. With that, I'll turn it over to Dr. Katamanchi.
Great. Thanks, Priya, for the introduction. Just to confirm that the right view is on the screen.
No, I actually see your presenter view.
All right. Let me swap displays. Is that better?
Great. Perfect.
Perfect. Great. Well, thanks, everyone, for joining the webinar today. As Priya mentioned, Achilles and I will sort of give the first, I guess, couple series of talks. And we're going to focus on implementation science to improve the quality of tuberculosis care. I will start with an overview of sort of implementation science in the global health context, and then Achilles will take us through a case study from some of our work in Uganda. So these are the kind of learning objectives. So we hope at the end of this combined session, participants will be able to describe the need for implementation science, understand key principles of implementation science relevant to the improvement of global health service delivery and care, cite examples of their application to TB services and care. And for us, we'll go over a case study focused on implementation of molecular testing for TB in Uganda. And then through all of this, we hope this will help you identify opportunities where implementation science can be harnessed to improve healthcare delivery in low and middle income countries. When I talk about implementation science, I often like to start with this, right? We often know what to do. We have lots of health research expenditures that are focused on developing new interventions. The slide here shows a range of interventions which are proven to be highly efficacious and effective across a range of health conditions, spanning, maternal and child health conditions spanning pre-pregnancy through early childhood. And what the bars show is the uptake of these interventions in low and middle income countries. And what you see is across, this period of the lifespan from pre-pregnancy through childhood, the vast majority of these interventions, which range from, things like, pregnancy planning to antenatal care, all the way through to, to vaccination and other sort of proven sort of interventions, uptake or coverage is less than sort of 50% for the vast majority of them. So, we often know what we need to do or what we should be doing, but not actually how to get it done or how to actually get it to people who need these interventions. So part of it is a traditional approach to implementation, which Martin Eccles, who is one of the kind of founders of implementation science, described as the Islagiat principles. And what that stands for is it seemed like a good idea at the time. And so what this means is that we think about, when we think about an intervention, we try to put it into practice. We don't really have a plan for doing it. We try something out and hope it works. And if it doesn't, we try something else. And so the key problem is that we don't really try to identify or address factors that are critical for successful implementation. And it's just a kind of a test different things and try what works approach. So what are the consequences of this? So first, new research takes too long to get adopted. In one analysis, it was estimated that it took over 20 years for an intervention to first be published as efficacious to when it actually received uptake in routine care. Many interventions are not aligned with the needs and priorities of patients and communities. And I think this is particularly true in global health, where we develop interventions in one context and sometimes often assume that they're appropriate or relevant for another context. Providers lack the tools to implement relevant and effective interventions, right? So again, we spend a lot of money developing interventions, but at least until recently, we don't spend a lot of time and money on thinking about what are the tools and strategies needed to actually facilitate uptake of those interventions. And last, there's variation in effectiveness or practice in different settings, and we're surprised by this, right? So we wonder why an intervention has high uptake in one setting but not in another, or putting the intervention into practice results in good outcomes in one setting but suboptimal outcomes in another. So we don't really sort of seek to understand the sources of variation or the different factors that might contribute to intervention uptake, right? And therefore are surprised by the variation that occurs. So implementation science is a discipline that's about a decade or so old, maybe a little more than that now. And really, this slide is intended to kind of give you some sort of definitions. So the first is from the journal Implementation Science. They describe it as a study of methods or strategies to promote the systematic uptake of proven interventions into routine clinical practice. Right? It includes the study of influences on the behavior of patients, providers, and organizations in either healthcare or population settings. The next definition is from the NIH Fogarty International Center. Again, it focuses on the studies of methods to promote integration of research findings and evidence into healthcare policy and practice, and also highlights the need to understand behavior of healthcare professionals and other stakeholders as a key variable. And last, this is from the World Health Organization, right? And they define this as the study of processes used in the implementation of initiatives and contextual factors that affect these initiatives. So it's not just whether or not something is working, but how and why implementation is going right or wrong, and testing approaches to improve it, right? So I think the common themes across these definitions, right? Implementation science involves understanding behavior, right? And so if people were doing what we already want them to do, right, then we shouldn't have an implementation problem. So ultimately, we need to change current behavior, and to do that, we need to understand behavior. Then we need to develop, appropriate strategies to change behavior, and then do all of this sort of engaging stakeholders to understand what the challenges and their perspectives are. And we do all of this to increase the speed, quantity, and quality of evidence uptake. So when I think about sort of the utility of implementation science, I kind of like to present an overview of this as a logic model, right? If we start on the right side of this slide, I mean, our goal is to improve the quality of healthcare, and we do that by, increasing uptake of evidence-based interventions. Oftentimes, again, what we do is, we just test something out, right? An implementation strategy, which is all the way on the left, and we hope that it leads to evidence uptake and improved quality of care. What we don't do is really think about all of the things in the middle. What are the behavioral factors and the environmental factors that contribute to evidence uptake? What are the personal determinants of those behavioral factors and the contextual determinants at different levels of the environmental factors? Is the strategy that we're using to facilitate uptake, is it actually targeting the determinants, modifying them, and modifying the behavioral and environmental factors, which we think will result in evidence uptake? And so the goal of this approach is to really understand all of this stuff in the middle so that we're developing appropriate implementation strategies. And importantly, as a science, we're developing a pathway where we can measure, is the strategy actually modifying the factors that we intended to modify? The other utility of this is that, when thinking about implementation in different contexts, right, it's important to understand, are the same, behavioral factors, environmental factors, and determinants present in one context versus another? If not, then it may not be the same strategy may not be appropriate in one context versus the other. On the other hand, if there are similar, determinants and factors involved, right, you can expect that a particular implementation strategy is more likely to be generalizable to that other context. So this is not, to me, this way that we develop drugs or other biomedical interventions, right? We don't just pick a compound and hope that it works and has the intended health effect. We study the biologic or chemical pathways in detail, understand which receptors need to be triggered or what the potential side effects of doing so are. And then we understand whether the compounds actually bind those receptors to what affinity, et cetera, right? So all of those things are studied in detail in preclinical development before you have a drug compound that's ready to be tested. And I think that's the approach that implementation science takes, is that we need to develop a causal model of the problem, and then target our strategies to address the causal determinants that influence evidence uptake. So to do that, implementation science relies on the use of theories and frameworks, right? And so Immanuel Kant said, theory without empirical research is empty, but empirical research without theory is blind. So many of us are sort of applied implementation scientists. And what I mean by that is that, we may not be the ones developing new theories or frameworks, right? And that aspect is also really important. And thankfully, there are many in the field who are doing that. But for those of us who are doing applied work, we still need to understand these theories and frameworks and use them to guide our work. And we use them to identify determinants of behavioral and environmental risk factors, to create a causal model of the problem, to specify which determinants are being targeted for change, to select appropriate intervention methods to match those targets, and then to inform, what are the outcomes we're going to measure to evaluate the implementation strategy. So implementation science frameworks, there's lots of them now, and they're different uses for different frameworks among these 5 kind of generic uses I've listed on the slide. I'm not going to go into the detail of all the frameworks. That's a longer sort of discussion or a longer webinar. But just to know that it's key within this field that there are models and frameworks one can use to inform each of the things listed on the slide. So just kind of getting to the end, I just wanted to highlight again the difference between kind of efficacy, effectiveness versus implementation research by just highlighting, the types of questions that might be asked, right? So an efficacy or an effectiveness question might ask, does preventive treatment with 3-HP reduce incident TB in high burden settings, right? So this is like the Prevent TB trial that was published in the New England Journal, proving the efficacy of 3HP relative to the routine daily isoniazid regimen for TB preventive therapy. So once that efficacy or effectiveness data is available, an implementation question might be, can digital adherence tools facilitate completion of self-administered 3HP treatment? Right. So here we're no longer focused on proving that 3HP is efficacious, right? But more on, can we increase its uptake and completion? Similarly, an efficacy or an effectiveness question might be, what is the yield of household contact tracing for identifying active TB cases? Right. So this type of study might go into a WHO guideline review to either recommend or not recommend household contact tracing. I think many of us know that these types of studies have been done, and contact tracing is recommended by the WHO based on efficacy studies like this, showing that it has high yield for identifying both prevalent TB and identifying people at risk who should receive preventive therapy. So once that data is available, a implementation research question might be, is clinic-based or home-based TB screening and testing more cost-effective for scaling up household contact tracing? So again, the implementation question focuses on methods or strategies to facilitate uptake of an effective or efficacious intervention. So with that, I will end my portion of the slides, and I'll invite Achilles. Sorry, Priya, you've jumped on, so maybe. All right, perfect. So invite Achilles to talk about some of our work that's focused on applying these principles to implementation of Expert MTB RIF, which is a molecular test for TB in Uganda. So Achilles, please take it away. You're on mute.
Should I share slides, or you want to move them for?
I can advance them if that's okay with you.
Okay, that's fine. Yeah, for sure. Thank you very much, Andy. Probably next slide, Aditya. Yeah, so probably the issue of TB diagnosis and the critical challenge of TB diagnosis has been shown like in the cascade of TB care, which was done in India, this study. It really showed that there are many prevalent cases of TB in the community. However, out of those that in the community, a few of those reach TB diagnostic centers. And of those which reach, few are diagnosed with TB. And finally, even fewer, like 53% in the cascade of care for TB in India, really were registered for TB treatment. So there is a loss of TB in all along the cascade, as you can see from there. This story is not different from my country, Uganda, though we have not had a critical analysis, but we are losing patients from the time of diagnosis to the time of holding the people on TB treatment. Next slide. So in a few years ago, the expert TB, MTB was developed. And when this came in changing, we had an old test really for diagnosis, the smear microscopy test. And that's a test which is more than 100 years, less sensitive. So when expert came in, there was a lot of expanding of the expert test. Here it's a semi-automated, detects TB within 2 hours and is highly sensitive. So it was thought that this test would be a game changer. And there was significant donor and country investment and scale up. As you can see there, the scale up of cartridges and the scale up of modules really went high in a few years. And this was done a lot in developing countries, and in particular, South Africa was one of those countries which did a lot. But this story was not very different from my country in Uganda, as I will show you. So in Uganda, really also as a country, we did a lot through donor funding and support to really expand. So you can see that those red dots is where expert is sort of distributed in the country. In almost all districts we had, but we could not have actually a gene expert device at every point where patients reach. So a hub-spoke model, really having the lower health centers, level 3, refer samples to the where gene expert is. So that was the hub-spoke model to make sure that people can access this test. And we had a lot of increase in MDR-TB cases detected because of that. However, there was mild increase in TB cases notified annually, and also the proportion of bacteriologically confirmed TB cases was from 60 to about 70%, which was low, and maybe that may have been due to the increase in number of expert tests. So there were a number of unresolved questions there that how well are these networks from the hub, from the spoke to the hub functioning? What is the quality of TB diagnostic care within the expert referral network? And what policy changes and core interventions can further enhance expert? And this is the work that we have been doing over the number of years, to really try to address these questions and try to inform programming. So, and our work was expert performance evaluation, here to facilitate linkage to TB care, which we call the XPEL-TB. And the aims of this really was to quantify the gaps in the TB diagnosis at health centers linked to the expert testing sites, to identify those modifiable barriers to high quality TB diagnostic services by really talking to the providers, the patients, and also identifying barriers at the health systems level, and to develop and test a theory-driven intervention to improve the quality of TB diagnostic services. So in order to define the quality of gap as our aim 1, what we did, we identified 24 health centers, which were the spokes linked to 16 expert testing sites. And this we did it together with the National TB Program, and based on the 2015 NTLP CAS notification, to identify those sites where we could work. And those sites needed to be within at least a distance because of cost, which could be reachable, but they were all outside Kampala city. And this was a prospective cohort study, and all others undergoing TB evaluation were included. How did we collect data from those sites? This was more collecting data really from routine records. We didn't introduce any new records. Really, we used the sources that exist: presumptive TB register, TB laboratory register, expert requisition form, TB treatment registers. And what we did, we provided a smartphone to each of those facilities which had been selected. And we trained healthcare providers who are not involved in the TB evaluation to take photos of those registers and submit them to a red cap developed server. And then one of our staff, whom you can see here in Kampala, would extract that data and enter it into the records. And once it entered into it, then we would resolve any queries by calling back to the clinics, and maybe they could go there quarterly to resolve any other issues. So data collection used routine records, and we didn't include gene expert alert server data used to ensure complete capture of these expert results. Next slide. So for the quality of TB diagnostic evaluation, as based on the international standards of TB care, really we identified 4 indicators to evaluate that. And this is work we did for January to December 2017, looked at 6,740 adults. And indicator 1, we looked at the proportion referred for sputum-based testing, and it was 79% on average. Indicator 2, proportion completing recommended TB testing if referred as per the guidelines, 56, and the proportion treated within 14 days if smear or expert positive based on the guideline, 75%. And the proportion receiving international standard TB care guidelines, recommended care, was 42%, meaning that you had a 42% chance of being diagnosed and treated within you came in. So it was quite low compared. And of those people, if you look at it, 17% of the patients referred for expert testing, and 34% were HIV positive. 7% of HIV negative others. So as the recommendation at that point was that whoever is HIV positive, the first test should be expert testing, meaning that all would have been referred. But if you look at less than 5% of patients referred for expert testing as first-line test, lower than even the people as per the guidelines. Less than 50% of expert positive patients initiated treatment within 14 days. So meaning that as much as Uganda had really put out a number of expert machines everywhere in the country, high coverage of expert testing service does not necessarily equate to high quality care. And that's one of our motivation to try to understand the quality gap. Here we applied the theory of planned behavior, which really shows that the intention to follow guidelines will be affected by people's knowledge, skills, attitude, social norms, and self-efficacy. But this will be affected by patient characteristics, factors like time, distance to access care, cost to access care, but also health systems factors will affect the clinician's intention to follow these guidelines, and physical resources, availability of resources for diagnosis, material resources, and so on. And so this would affect whether the clinician providers adhere to those international standard guidelines and lead to improved case detection and treatment. So we use that model to understand this. After using that model, those barriers which were identified, we now use the PRECEDE framework to understand the recurring themes from that. So along the predisposing factors, we looked at time and resources constraints, high workload, which led to low self-efficacy, belief that TB evaluation is not urgent. Among the enabling factors, factors that, if addressed, make it easier to initiate the desired behavior. Failure of patients to return after initial visit due to time and costs. Inconsistent late specimen transport to expert testing sites. And inability to track and follow up patients. Actually, one quote from one of the people, when they have a cough for more than 2 weeks, they are sent to the lab. But the problem is that they get the first sample, and sometimes, actually most times, they don't bring the second sample. So meaning, then that's a quote from one of the providers. Among the reinforcing factors, lack of communication and coordination among staff, insufficient oversight from the National TB Program. And a quote, actually at times we have met, but we don't meet regularly. Only when we realize there is a problem, that's when we communicate and say, why is this happening? Then we try to rectify it. So this is how we understood the barriers and the recurring themes, and those recurring themes led to the development of our intervention that we wanted to test. Next slide. So to improve the quality gap, in this case, we had to design the intervention based on those recurring themes. And we had to review the evidence that exists in the literature to guide us in the development of the intervention, but also stakeholder consultation. It's very important to work closely with the National TB Program and other stakeholders to come up with something that would be feasibly implemented, so that then prioritize some of those barriers and select interventions and specify how these interventions would be delivered. Yeah. Next. So based on that, we came up with the Expero TB intervention strategy, which has 3 components, a multi-component intervention. For on-site expert testing at the health center, expert age, really trying to have it placed at the spoke. It would reduce workload among those barriers, increase speed and accuracy of testing. Then we structured the clinic process, redesigned to facilitate same-day testing and treatment of TB to address lack of urgency and failure of patients to return. And we provided regular feedback of quality metrics, health facility staff, so that to improve communication, coordination, and oversight. So this was the Expero intervention strategy, which is 3 components. And then led to the trial, which trial we conducted, and to evaluate the effectiveness and implementation and cost effectiveness of that Expero strategy at community centers. So the multi-component diagnostic strategy, which is on-site molecular testing as first-line test for TB, streamlined clinical laboratory and pharmacy workflow, and monthly performance feedback, was implemented at 10 sites. And also we compared it with routine care, sputum smear microscopy as the first-line test for TB, referral of high-risk samples to molecular testing hubs. And this was a cluster randomized hybrid implementation trial at 20 health centers in Uganda. All adults were evaluated for primary TB from October to March were eligible, and we excluded patients with rifampicin resistance. In order to buy in and even to work closely with the communities, we organized a public randomization ceremony. This public randomization ceremony, people were taken through the procedure and that by Catherine from London School, who was the statistician, and people came and participated in choosing which sites will be in the control, which site will be in the intervention. And so the people chose, and finally, that is a picture showing, and this was published also to show that people agreed to be in the control and agreed to be in the. And this was ultra programmatic features. We waived informed consent. There were no trial-specific changes to usual care. Outcomes assessed using routine data sources and minimal contact with health centers, except at the initial visit during the training and quarterly visits to resolve any data queries, and conducted nested sub-studies. Next slide. So the outcomes were both primary and secondary. The primary outcome was the number of patients treated for microbiologically confirmed TB within 14 days. And secondary outcome was along with the cascade of TB care, number completing TB testing per national guideline, number diagnosed with confirmed TB, number treated for confirmed TB, and number treated for confirmed TB in 1 day and 14 days. So this will show you, we worked with the National TB Program to select 20 out of the 84 eligible health centers. And these treated more than 10,000 targeted population adults, and very few people were excluded from this. The harmonic mean number of patients higher in the intervention arm, 456 versus 366. So the patient level characteristics, the intervention and control arm, as you can see, were similar. Really, they were all similar on female age and HIV status. They were similar. On the primary outcome, we see that people who received the multi-component intervention were 56% more likely to be treated for confirmed TB within 4 days evaluation as compared to those in the control. Yeah. Even when we looked at the subgroup analysis of the primary outcome, even when you look at among males, it was 59%. Among females, it was 46% were more likely to be treated in the intervention as compared, except for the HIV negative, where did not receive statistical significance, but was still higher number of people. Along the cascade of TB care, it's a secondary outcome. Really, we see that even when we did this, the people who received the multi-component intervention were more likely to receive diagnosis of confirmed TB, were more likely to be treated for confirmed TB, and treated for tuberculosis, irrespective whether it was confirmed or not. This similar trend for both same day and also for 14-day outcomes. High implementation fidelity and improved quality across the cascade of care was very clear in this trial.
Achilles,
Yes.
would it be all right in the interest of time if we move to the conclusion and we can discuss other aspects of the results in the discussion? Thank you.
Okay, conclusion, scale-up of novel diagnostics alone is unlikely to significantly increase case detection or improve patient outcomes. The Expero TB strategy on-site expert testing increased 14-day TB diagnosis and treatment by 56%. It improved quality metrics at each step along the TB diagnostic evaluation. National TB programs should consider decentralized molecular testing to close the case detection gap and improve quality of care. Implementation science-based methods are useful for designing and evaluating health systems interventions to improve the quality of care. So just to thank very many people, this study was funded by NIH and led by Aditya Katamanch. It was published in the New England Journal of Medicine in 2021. Thank you very much.
Thank you, Aditya and Achilles, for that really comprehensive presentation. We're going to move to our third speaker, but as Karen is getting queued up, I will just check the chat. Okay, good. We do have a question. I think the Aditya and Achilles moved through this in the interest of time regarding cost effectiveness analysis and incremental cost effectiveness results. Feel free to perhaps answer in the chat if you don't mind, Aditya or Achilles. But I had one maybe a higher level kind of question for you. For those in the audience and others who might be just starting out in this methods area, Aditya, you did mention the difference between efficacy studies and trials and implementation science related questions. But I'm wondering if you can briefly talk about, using this case study as an example, what the difference would be for someone in terms of using methods like yours in implementation science versus people using operational research or people using quality improvement methods. What are the differences there, and how would one decide?
Yeah, no, I think it's a good question. I mean, I think I think it's important to realize that these disciplines, whether you call it operational research, implementation science, quality improvement science, they're all aiming to improve either program performance or performance in delivery of care at either at the health center level or regional systems level. So think they all share the same goals. They come from different sort of traditions, right? Operations research was, often done by programs or specific health centers, often sort of with or without sort of a lot of sort of formal research and training background. And the idea was to really use and leverage program data to try to kind of understand what the quality of care was, and again to kind of try different interventions to improve it. QI comes from a tradition of industry where and manufacturing, where you're really trying to fix the problem on that one manufacturing line. You're less concerned about creating generalizable knowledge and results that might be useful in other settings. But again, I think these things are merging and changing over time, where now there's more of a blend where even I think very good QI work is using approaches to better understand what are the factors and barriers involved, and these fields are merging. So I think it's really kind of, they come from different historical traditions, and they're all kind of now, I think, doing a better job of especially if you want to use it to generate generalizable knowledge that might be useful in other settings, similar approaches and frameworks, right? And they may call them by different names, but the goals are the same to do that.
Great, thanks. Why don't we move now to Karen Webb's presentation. Karen, I previously introduced you. I think you were still logging on, but welcome, and we look forward to hearing your remarks and more about the context in Harare, Zimbabwe.
Great. Thanks, Priya, and thanks to everyone for the opportunity to be able to share some of these lessons that we've had in our collaboration together with many in, sorry, I'm just going to, if you just let me know if you can see my screen.
Yes, we can see it.
Okay, good. Thank you, Achilles. So hi, everybody. Sorry, I'm at a function right now, and I'm in a function room. So if I cut, I'll keep trying to log on. Our internet in Harare can sometimes be a bit dippy. So I'm just going to present a case study about our experiences integrating implementation science within a programmatic setting. So my name's Karen Webb, and I'm the Deputy Executive Director at OFID. Slides, there we go. So OFID stands for the Organization for Public Health Interventions and Development. We're a local Zimbabwean NGO, and we develop and implement innovative approaches and evidence-based strategies to strengthen the provision of primarily quality HIV prevention, care, and treatment services, and of course related comorbidities, including non-communicable diseases and also HIV and TB affected households. So we've been operating for over 20 years in Zimbabwe. Our headquarters are based in Harare, but we also have provincial and district level presence at a very highly decentralized structure. And our primary purpose is really to support the Ministry of Health and Child Care with implementation fidelity of existing guidelines and recommended practice, evidence-based practice. So our model for working that we use, in the center you can see programs at scale. So we're an implementing organization. We're not a research institution. So really our primary purpose is to improve the quality of health, of services, and of course, quality of life of the recipients of care that we support. But related to that, and to continuously improve and improve the fidelity of recommended practice, we implement what are called incubator projects. And these are small scale projects and research interventions that seek to not just develop and test clinical and social innovations, but also to really understand, excuse me, as we know, evidence-based practice might come out of an intervention, but there's very many reasons, as Aditya said, why that isn't happening in context. So what we really try and do is integrate implementation research, program science, and operational research to continuously improve and iterate our practices so we can improve the scale and the quality of services that we provide. And we also seek to strengthen other local organizations and integration of services such as mental health, non-communicable diseases, together with other local partners. So within the context of the case study that I'll share today is our largest program is a PEPFAR funded program through USAID, which is called TASK, which stands for Target, Accelerate, and Sustain Quality Care for HIV Epidemic Control. And really the goal of this program is to contribute to the achievement and sustainability of epidemic control through both community and facility-based services. So this we implement at over 320 public health facilities and their surrounding communities. So we have both community-based outreach services as well as facility-based services. And related to this is complementary TB, cervical cancer, mental health, and maternal and child health programs. So the case study I'm going to share is actually done in collaboration with Priya and her team at the University of California, San Francisco through the SPRINT study. And this is really looking at evaluating the impact of social protection on tuberculosis and HIV outcomes in Zimbabwe. So as a little bit of background, I think many on this call, probably all of those on this call are aware that these catastrophic costs associated with tuberculosis treatment, and these are a major contributor of poor health outcomes. And also the coverage and gaps within existing social protection services serving people affected by TB and people living with HIV has not been traditionally well described in general, but specifically within our Zimbabwean context. Despite this, there is global social political commitment to increase social protection coverage, originally aimed at 75% of all eligible people living with HIV, but this has been reduced to 45% because of low and unmeasured coverage. So there's a lot that we don't know about the integration of social protection and health programs, specifically TB and HIV. So together, we sought to conduct implementation research amongst people living with HIV in terms of their access to care services, to describe their experiences of socioeconomic disadvantage and unmet social needs and savings, and also to evaluate the frequency of social and economic vulnerabilities on HIV, both HIV and TB outcomes. And then finally, to examine the coverage or access. So amongst those that are receiving HIV and TB care and treatment, how many have actually ever accessed social protection programming? So the results that I'll share with you this evening or this morning in some context were done through an exercise conducted from January to March of 2023. And this was done in collaboration with the Zimbabwe network of people living with HIV, who conduct a monthly client satisfaction cross-sectional survey. So this survey is done with recipients of HIV care who have accessed HIV care in the previous month. And really, it's meant to assess the quality of services, their satisfaction with those services, and also specific characteristics that we might be able to use this data for improving the quality of care that we provide. So the exposures that we measured were sociodemographic factors, unmet social needs, specifically lack of funds for food, transportation, and also measuring using validated tools such as the multidimensional poverty index. The socioeconomic outcome was experience of savings, and the clinical outcomes that we looked at were HIV viral load suppression in the previous 12 months and TB co-infection. So a little bit more, I won't get into too much detail about the client satisfaction survey, but this is just really something and demonstrates the power of kind of integrated and collaborative implementation science from our perspective. This is a routinely collected data set. It's collected with thousands of individuals that have accessed HIV care in the previous month, as I said. And it really looks at accessibility, affordability, availability, appropriateness, and acceptability of the services that we're providing. So it's really intended to be a quality improvement tool and to use evidence to direct our programming and prioritize our actions. So the preliminary results that I will share are amongst a group of 3,634 people living with HIV that have accessed care and been surveyed through the client satisfaction survey. The median age of those that were surveyed was 44 years, and the majority were female. And this is consistent with the general, those amongst, excuse me, within HIV care and treatment in Zimbabwe because of the high level of diagnosis within antenatal and postnatal care. So the multidimensional poverty index is a measurement of poverty along 3 dimensions: monetary poverty, education, and basic access to services. We also measured unmet social needs, specifically lack of food, funds, or clinic costs for transportation. And I think it's really important to mention that it wasn't just multi-dimensional poverty or unmet social needs into savings, but it was also specifically about people's ability to either access or adhere to their HIV care and treatment or TB treatment. So looking at multidimensional poverty, we could see that nearly half of all of those within HIV that had accessed HIV care and treatment in the previous month were multidimensionally poor, and a further 26% were vulnerable to being multidimensional. Having multidimensional poverty. And then in terms of viral load suppression, we can see a very clear relationship between multidimensional poverty and both having an unsuppressed viral load, which is greater than 1,000 copies per milliliter, and or being HIV TB co-infected, being diagnosed with TB in the previous year. In terms of unmet social needs, 46% of those that had accessed HIV care and treatment indicated that they had a lack of food for either themselves or their family that impacted their ability to access or adhere to HIV treatment. And amongst the number of unmet social needs, while 48% indicated that they had no unmet social needs, we can see increasing numbers from going from 24% with 1 unmet social need to 15% with three unmet social needs, which is significant vulnerability. However, fewer than half of those reporting food insecurity into savings indicated that they had been ever received access to social protection programs. So we can see for social protection access by food insecurity, amongst 1,673 individuals who reported being food insecure, only 45% had ever accessed any form of social protection programs. And then for savings, amongst 1,902 individuals who reported savings, fewer than 40% had ever accessed social protection services. And here we can also see that individuals experiencing multidimensional poverty were at increased risk of having unsuppressed viral load. So as we can see, for amongst those that were poor or severely poor and had not received social protection programs, were at 3 times greater risk of having unsuppressed viral load as compared to those who had accessed social protection services. So what this is really telling us within the context of an existing implementation program is that we could see very strongly that multidimensional poverty, unmet social needs, and savings are widespread amongst people living with HIV in Zimbabwe, with food insecurity being the most prevalent. There's a mismatch between those who reported need for social protection services and the type that has been offered or made available. Less than a quarter surveyed had received social protection programs, and less than half of those that needed them had ever received them. So public health and clinical outcomes such as HIV, viral suppression, were clearly associated with impoverishment and unmet social needs. And while we can see that social protection services would certainly improve the clinical outcomes of these clients, that these services were not currently being offered or accessed. So there's clearly a disconnect between the understanding amongst our programs that we need to be providing this type of integrated support and the provision of that support. So looking at implementation strategies and implementation questions, really this leads us down the line of how do we do this? Where should we be doing it? And amongst whom should we be prioritizing for these types of integrated programs? Aditya mentioned that he quoted 20 years, but it takes an average of 17 years for research and evidence to reach clinical practice. But we can see by integrating and collaborating on implementation science that we've done this within the context of an ongoing program. So there's very much what we term as like a Hawthorne effect of conducting implementation science within existing programs. By the fact that we're looking at it, it's already changing practice, and it's increasing our awareness and hopefully improving the quality of care that we provide in practice. But it also points us towards more appropriate implementation science questions. So this is just a few members of our team that we've been collaborating with, and I think a big takeaway for us on these collaborations is that it's bi-directional capacity building. We're improving the quality of our programs, the quality of the evidence that we're generating for making program decision-making, and we're also translating this within existing policy and practice. So a lot of these programs have actually gone on to change existing policy and practice. So I think that's about it for me. I'm very happy to answer any questions, but we're just really grateful for these collaborations. In the top hand right, you can see Rutendo Mukondwa is our project coordinator for this program. In the bottom right is our strategic information and evaluation team, where we use this routine data within implementation science questions. And then, of course, Priya and the team at UCSF, who we're really grateful for this collaboration. So thank you, Tatenda Siyabonga from Zimbabwe. Thanks.
Thank you, Karen. Great. Achilles, Aditya, if you could all come on briefly for a second. We don't have a ton of time, but I had a few questions, and please, for others, post your questions in the chat, and we will either type in responses or I'll flag them. So I think in both cases, what I heard that was similar across these studies and settings is this idea and need to kind of identify gaps in the provision of evidence-based or evidence-informed practices and interventions. And I'm a little bit curious about the reverse, which is, what is the scope of implementation science and actually informing policy and guidelines, and how has that changed over the last few years? And I know, for example, in the diagnostic landscape, Aditya and Achilles have been doing a lot of work in that. Karen, you and your team have been doing a lot of work.
My network is turned off. I let Aditya maybe go.
Okay, no problem. And then Karen, you as well in the terms of policy recommendations in Zimbabwe. So can you speak to the reverse now, going from practice to policy?
Karen, do you want to go ahead, or I can go ahead, Karen, and I'll jump in after.
Yeah, thanks. Yeah, I'll be brief. So from practice to policy, it's this bidirectionality that we continuously face. So I think certainly in our context, very resource constrained context, both in terms of human resources and material resources to provide the care that's evidence-based. Do we have all the commodities we need? Do we have, there's many different moving pieces that we're often lacking to be able to realistically and with fidelity implement what we know is evidence-based. So in terms of moving from policy to practice, what we find and where implementation science and specifying our strategies really comes into importance is simplification. A lot of our guidelines are overly complex and perhaps do not translate from policy level down to the primary healthcare level or the community level, where these services and the majority of individuals are actually accessing these services. So I'm not sure if that quite answers your question, but I think in terms of where implementation science really has value and power within our context is really to how do we make something that's quite complex and an ideal context into what is implementable given a wide range of challenges in context. So to make it as best we can. Thanks. Go ahead, Aditya. Thanks.
Yeah, I mean, I'll just add to that. I mean, I think there's a huge need for practice to inform not just policy, but also the interventions that are needed. And I think an area that's, I think starting to receive more attention. I mean, oftentimes, policy or even intervention development goes one way. It goes from science down to sort of public health or practitioners or clinicians. But really, we need to be understanding the preferences of people delivering care and receiving care for the types of interventions that they want, and the characteristics of those interventions. And I think that's an area where implementation science can really sort of help to understand and characterize, not only what the gaps are where interventions are needed, but then what the preferences around stakeholders who are actually going to be consuming those interventions are, to inform more appropriate intervention development. One of the things I highlighted was that interventions are not often appropriate for the context in which they're being delivered. And so really understanding what those preferences are can guide and help inform the right interventions to be developed.
Great, thanks. And I think I'll just end with one last question while I have all of you online. It's a rare kind of perk of this job. Is this idea of integration. And I think increasingly people are talking about integration in a variety of ways. So for example, in the context of lung health and certainly in tuberculosis or HIV care, there's integration of those types of services, but in some ways they're still siloed. Karen, you talked a lot about integration within programs of different multi-sectoral strategies that are not typically done in health settings or health systems. Aditya, you and Achilles talked about the integration of kind of novel diagnostics and novel tools in kind of community health centers where those weren't previously available. And there's increasing discussion about differentiated health service delivery, integrating lung health with a variety of other things. I'm just wondering what you all think the scope is of implementation science in supporting that, and whether it's, does it have to be so micro level in terms of behavior change, or are there things we can gain from like a systems perspective in that regard?
I'm happy to start on this one. I mean, I think certainly, you look at this from the perspective of someone seeking healthcare, whether it's for cough or anything else, they're not interested in only a particular disease program like TB, right? They want an answer to why they're having a symptom or what's sort of going on with them. But as you highlighted, the organization of our care, particularly for public health, in many countries, is that if they're undergoing TB testing and they don't have TB, then they sort of just there's not necessarily a clear program sort of for them to follow. And so I think where implementation science can be helpful is in getting perspectives of stakeholders, whether it's the policy level, at the ministry level, and then down on how care can be reorganized. It's too bad that Achilles and Network Connections Board, I know he's been involved in a project that's actually called Reimagining TB Care. And a lot of that is trying to sort of reorient care from the patient perspective of the person who's actually coming in to receive that care, and how can it be delivered to address that whole person's needs, and not just focus on whether or not they have TB, which is the focus of the National TB Program, for example. And so I think where implementation science can be helpful is to gather the perspectives from the different stakeholders at different levels, and to organize it in a way that people can think about how systems can be redesigned and reorganized, and then to test those approaches to see whether they're having, the intended impacts that stakeholders want.
Thanks. Yeah, without duplicating, I think I agree absolutely with what Aditya said, and participatory methods, we get these kind of buzzwords in programming, co-design, human-centered design, but it really is, we're increasingly seeing it has to be acceptable and feasible, both by the consumers of the service, but also particularly by the providers of the service within context. Just putting it, as an example, implementing at a primary health facility in a rural area in Zimbabwe is very different than in a high density urban area. And so we might have a single policy and a single intention to provide TB treatment or HIV treatment, but context certainly it affects greatly about how that service is either offered and the ability to sustain or adhere to that service. So really understanding, using implementation science, how the different modalities of implementation can affect the outcomes is really critical. Thanks.
Great. Well, thank you all for your really interesting presentations and thoughtful comments. This will be the close of our webinar. For those who have joined, we are grateful for your participation. I believe you will receive a recording or slides. I think that'll be available to those who participated. I think the closing kind of summary of what I've learned and gained from the discussion is that implementation science can be a really powerful tool for improving quality of care and public health outcomes, primarily because it seeks to identify contextual factors, locally relevant behaviors needed to enhance uptake of what we know to be good care, and to do it in a way that's equitable and in keeping with what's required and preferred by those end users, clients, patients, and communities that we're trying to serve. For those who require any additional help with thinking about implementation science for your own projects or et cetera, please feel free to reach out to me or any of the panelists today. We'd be happy to help direct you or talk more about this really interesting topic. So thanks very much for your participation, and please enjoy the rest of your day or your evening. Thanks very much.
Thank
Thanks,
you.
everyone.
Bye-bye.